Good morning. My name is Key Park. I'm one of your co-moderators for this session. I'm a surgeon by training. I'm the Director of Policy and Advocacy in Programming Global Surgery and Social Change. This is my co-moderator, Joanne Manrique. I just want to first thank all the panelists, distinguished panelists for their time. I want to thank all of you here, and I also want to welcome those online. Welcome. So to set the stage, this session is really has two parts to it, and let me set the stage on the equitable delivery of surgical care. About 8 years ago, there's a Lancet Commission on Global Surgery, and it was published, and it talked about the unmet surgical needs around the world. 5 billion people do not have access to timely, affordable, and safe surgical care. 143 million additional operations are needed each year that are not being done currently. And there's actually an economic cost. It is estimated that over $13 trillion are lost in GDP if we fail to act to scale up surgical care. So we've been working on strengthening surgical systems with a number of countries, working with WHO. And we've been doing this for several years. And the problem is we've sort of hit a wall. And the secret is not, you can see what, we don't have the financing, a sustainable model for financing to implement these beautiful national plans that a number of countries have developed, including Zambia. So this session really looks at how do we unlock partnerships with the private sector. And when we talk about private sector, we define it rather broadly. It's not just about industry, who's here. It's not even about private facilities that deliver health care, but also looking at private capital. What could they do to help deliver equitable surgical care? So let me stop there and turn it over to my co-chair, Joanne.
Thank you so much. I'm Joanne Manrique. I head up the Center for Global Health and Development, and we also house the Women's Health and Empowerment Network, which includes development finance institutions, women philanthropists and investors, and private sector partners. And we are really honored to be working with Dr. Key and the Harvard Global Program, and then also J&J in the Partnerships for Equitable Surgical Care. One of the things as we're developing the Women's Health and Empowerment $500 million fund, as Key said, we need the financing. And how do we deploy that financing? And so we really are looking to the experts on this panel to look at how we look at those surgical care delivery interventions. Once we have the financing, how do we deploy that? So with that, I don't want to take any more time because I want to hear from the experts. I'd like to turn it over to Professor Roma, who's the special advisor to the president of Zambia, and is also Director General to Health Zambia National Public Health Institute. Professor Roma, you've been working with also the Women's Health and Empowerment Network partners on innovative business models for the delivery of care, and surgery is so essential to that. If you could talk about how Zambia is working with the national health insurance companies in finding new ways to engage the private sector and some of the innovative business models that you're thinking about.
Thank you, Joanne, and good morning, colleagues. It's a pleasure to be here, and thanks for the opportunity to be on this panel. Indeed, in Zambia, we are working on a program with the Women Health Entrepreneurs Network, as well as the Center for Global Health and Development, that we've been building for some time now. And basically it is premised on the fact that while government makes substantial investments for cancer care, there are still gaps in the system, and those gaps require really well thought strategies that will close in on those gaps. And one of the key issues is that to make a win-win situation, you've got to look at strategic opportunities in that ecosystem. And a key opportunity for us as we tried to look at what government is doing Number one was to recognize that government is making an investment into cancer radiotherapy services. And so off the back of that is really to work with Center for Global Health to try and look for matched funding and look for partners and donors that are going to invest in that space. And what is the best use of that investment is to figure out now a sustainable model that is going to help come up with an end-to-end sort of care for cancer diseases treatment in Zambia. And so a brief moment to talk about the Women in Health Entrepreneurs program that we are working with in Zambia is really that we have a lot of women in Zambia who are professionally qualified in various fields in the health space, including doctors, nurses, pharmacists, and the like, who the government is not able to take on formal employment because of limited fiscal space in the public budgeting. And therefore, we can begin to leverage that available human resource by empowering them to close very specific gaps in the provision of care for cancer diseases, be it from screening in community activities to ambulatory services to providing supportive care when these patients are in the health system, to even running private pharmacies and dispensaries that would help meet specific gaps that are in the system, as it were. Now, to do so, you need to have a system that is sustainable, that stands a chance to continue in the long haul. And our key strategy is basically to utilize the National Health Insurance Scheme, so that once a service is provided, it is basically meeting the required standards, and then they are able to be reimbursed or paid through the National Insurance Scheme. Now, for that to work, we have to obviously make sure that the National Insurance Scheme itself is working well. And in Zambia, that scheme is mandatory for people in gainful employment, and we are trying to figure opportunities. And I think there are many opportunities there, especially for private companies to come in, but also for donors and philanthropies, because the base of people in formal employment for whom it's easy to make contributions and collections is very narrow. And obviously, when we are looking at having an ideal minimum coverage package, you need to expand the collection for that health insurance mechanism. So there are ideas that we are looking at from the National Insurance Scheme itself, looking at private insurance scheme. How can we improve that? Starting with conversations at government itself, so that the ring-fenced funding for provision of health care is guaranteed. In Zambia, care for children under 5 is supposed to be completely free. Care for people who are over 65 years old is completely free. And so ring-fencing the funding from government budgets for those health coverage activities are conversations we are actively engaged in, and now looking to other opportunities with the private sector players like your mobile phone companies who are really having a very high penetration in the country, and there are specific opportunities there because mobile phone companies run banking schemes, basically we call mobile money, and we see opportunities in there that can be leveraged. There are other opportunities with road taxes that people pay and other taxes within country that that we basically mandate the public to contribute to. It's a question of how can we come up with opportunities and take advantage of those to leverage so that we increase the pool of this national health insurance scheme, which is in everybody's interest that it works. And the women entrepreneurs I was talking about, obviously, if we have a sustainable program for them, they then not only solve the problem of unemployment, but they also get into gainful activities that then get them onto the insurance scheme and start to contribute. So in a nutshell, these are the sort of things that we are engaged in, and we feel very optimistic about the program. Thank you.
Thank you, Professor Roma. I don't know if some of you in this room probably know the role Zambia has had in the global surgery movement. Professor Emmanuel Makasa was the health attaché at the Zambian mission in 2015 when he was instrumental in drafting the resolution for strengthening emergency and essential surgical care as a component of UHC. Zambia was the first country to develop a national surgical obstetrics and anesthesia plan right after the resolution. They followed through with the recommendations. And I have to say, you also started subspecialty training right after that, implementing the national plan. And one of the graduates of the neurosurgery residency program is currently a fellow with us, right? So this is it's really happening. Now, I want to go to Monique Vletter from the World Bank. She's the head of Nutrition, Population, and Health, and also the Global Financing Facility. Blended financing is not a new concept, right? You know, how do we align philanthropic money, concessional money, public funds with private capital, right? Where there's actual sharing of interest. Tell us about World Bank's experience with blended financing, lessons learned, and what kind of recommendations you have for us.
Great. I thought I would get some time to think about my remarks as I'm sitting all the way at the end, but so thank you. And I'm also very happy I'm speaking before some of the really smart people at this table who know much more about surgery than I do, but I'm really glad to be here. So maybe before I talk about financing, just to say that when I myself started looking at the issue of surgery and the massive inequity that we see, only 5% of surgical needs in Africa are being met. It's a tremendous issue, and I'm just really happy you put it on the agenda here because we're really not talking enough about it. When you look in Africa, the death toll due to road injuries and traffic accidents, there are 13 neurosurgeons in the whole of Africa, right? And so you can imagine what an incredibly loss we have if we don't pay more attention to surgical care. So I just wanted to start with that, and also recognizing that at the World Bank, we are not doing enough on this. And so we're very actively exploring how can we use our financing and the tools that we have to make a bigger contribution in partnership with others on this agenda. And there are 4 areas I wanted to highlight there on the financing. One is that all of our programs fund health systems, with at the core of that strong quality primary care and community-based services. And so the concept of primary health care needs to be broad enough to ensure that it can only work if the referral and the district hospitals can also provide those additional services to save lives when necessary, whether it's a C-section, an appendectomy, or treating somebody who was part of a road accident. The second part we're looking at is out-of-pocket expenditure. It's quite astonishing when you look at the data. For pediatric surgery, for example, in Africa, about 40% of families who have a child that needs surgery end up being impoverished by the expenses associated with that surgery. And so that part of the financial access to surgery care is another really important entry point. And then there's the quality. So if surgery then takes place, we don't always see such a good outcomes. And and complications that could easily have been prevented. And then the final is, and you refer to that in your question, is the relationship with the private sector. And so as part of the reorganization at the World Bank, we're looking at a more effective way of supporting private investments from IFC, also in hospital care, where the World Bank can play a more constructive role in terms of regulations. And so our government's ready to help regulate the private sector and set quality standards to ensure that there's more access, but also that the quality of the services that are provided are being guaranteed. So thank you very much.
Thank you. And if I can ask you a follow-up question, Monique, you've been such an expert leader in terms of the GFF, right, and the blended financing mechanism. As we're also looking at surgical care, as Professor Roma said, you need those innovative thinkings around insurance models. And I'm sure with the GFF, because I was on the original advisory committee, there's a lot of innovative thinking you're doing every day. How could you see some of the maybe country-specific models to get really practical in terms of the surgical care being, could we offset it with insurance modeling, or what's your thinking personally on it?
Yeah, great. So I have to be honest, I'm no longer leading the GFF since last year, but I'm still very happy to talk about it, as I was one of the founders of GFF. So there are a couple of things that are really important lessons from GFF. One is that the investment in CMOC. So we have countries that are doing excessive amounts of C-sections, right? I mean, Bangladesh, 67% of birth ends up in C-sections. So that means that there is a surgical capacity to do that surgery. And is there a way of, what we looked at in GFF is there a way of further building on that capacity to expand the scope of surgeries that are taking place? So that's one part. The other part is, of course, around what you were mentioning, the innovative financing agenda, and ensuring that in the work we do around domestic resource mobilization and financial sustainability, that in insurance packages, surgical care is well represented. And so that has been mainly the focus of GFF. And then, of course, with the current fiscal constraint, this is not just a longer-term conversation around domestic resources for health, but also a strong focus on using existing resources better, and in most cases, their scope to do that.
Thank you, Monique. Our next question will be headed towards Bente Mikkelsen. Okay, and she's director for NCDs at WHO. And the WHO is a technical agency, right? But once you have these beautiful plans and campaigns, how do we actually help deliver those people with care that they need, right? So can you tell us about WHO's approach to private-public partnerships in terms of caring for the people with, let's say, in your case, NCDs?
Is this on? Yeah. First of all, thank you for inviting us to this meeting. I think the core of the meeting is really how we are able to implement what we need to do. So that's really appreciated. First of all, it's important to be, clear on what WHO's role is. So we have, in principle, 3 roles. One is to provide global leadership. The other one is to provide normative work, guidelines. And the third one is to support implementation at country level. And I think this is important to understand from the onset. So we see that there is a power in convening an alignment that we are able to support also when we are looking into financing solutions. And I would like to first sort of make a step that is more broad than surgery. The member states of WHO, the World Health Assembly, are fully aware that we have huge shortcomings when it comes to implementation of NCD. And NCD in general represents 74% of all global deaths, 9 out of 10 main morbidities, and it is, as per now, less than 5% of international funding coming to NCD. So it's a completely inverse kind of relationship between the burden of disease and what is provided through overseas development assistance and international financing. I think for many years the NCD community was arguing that they wanted a global fund for NCD. We have totally left that track. I think all of us are fully in agreement that we need domestic or domestically managed funding for NCDs. So that is our starting point. So we believe that we have a power in putting out the normative work. So if I should apply it just now to cancer and surgery, we know that we have 75% of the countries having a national cancer plan, for example. Only 9% of those plans are budgeted. So planning is not the inroad to implementation necessarily. But planning can be a very good template for convening partners and find the complementary solutions and funding to implement in that exact country. So planning is important, guidelines is important, and I think we are in a safe place when we try to use this. Monique was already talking about the essential benefit packages. And that is where we believe the main inroad now is to address what is needed also for diseases that is in need of surgery. We need to have good essential benefit packages, which also describe what is needed to implement, not only mentioning the disease or the intervention, but also to have a full layout. What does it really mean for a country in the sense of technology, devices, medicines, but even more important, human resources? And that should be the starting point on the dialogue of any private-public partnership as well. Unfortunately, that is not what we necessarily see many times. Many times the supply side is very strong. It's a vibrant ecosystem for solution provision in the private sector many times, and that's very much appreciated. But when you look at the public side, our sort of ability to do the demand creation is very often missing. So I believe that the middle point of this is that if we align around the essential benefit packages with the guidance provided by WHO, but applied to the national level, and also live the idea, which we need to do, to make this a national governmental responsibility and accountability. So we try to avoid all these very interesting but not so efficient and sustainable solutions that are outside the government. The government need to be part of it and also be accountable for the implementation. This is nothing new, and it's not easy. If it was easy, we had done it a long time ago. But I think the environment is much more conducive now because of COVID. We saw that the private sector and the public sector were able together to find solution in a very speedy manner, and I think this is very inspiring. So I will end up with one example. So in an area that is not so surgical and less for the complication is diabetes. And we started off with diabetes because we had an innovation 103 years ago, namely to discover insulin. And when we realized on the 100 years anniversary that only 50% of those in need of insulin actually have access, we understood that we are not able as the world to actually, implement a huge innovation. So we set up a global diabetes compact, and we have done systematic public-private dialogues. And I think by WHO, on behalf of the countries, coming out with very concrete asks and seeing that the private sector is responding to this, and we are about to set up a register to also be able to look into accountability. But early sign of success is that we now have pre-qualification of several insulins and we have tech transfer and local production in some countries. I know it's not surgery, and I can continue with another example, but this is the most progress, and it gives me hope that if we apply a quite simple recipe, maybe we can do better in the short run.
Bente, you just gave some stark examples of how health is really a political choice. That's the theme of the WHS this year. And we're so lucky to have Professor Roma Chilengi with us from Zambia. We will come back to you in a bit because Zambia is a place where I think Professor Roma will explain better. They're really taking this private-public blended financing idea and then trying to really implement some of the things that the WHO is recommending. So this is where the rubber meets the road. So we'll come back to you, Professor Roma, in a bit.
Thank you so much. And Dr. Bente, you mentioned that, the two sectors, the public and the private sector. And one of the things that as, we're finalizing the $500 million close is that when we look at the implementation, you need those sectors. You need WHO at the table, and you also need the supply chain management. So I'd like to turn it over to Faustin, CEO of Africa Resource Center. As you've been hearing the conversation to date, Dr. Bente, Monique, Professor Roma, what are the unique things to deliver that end-to-end care for surgical care that is needed, both from the supply chain management, but also from the financial perspective? Because it's not enough to just have the plans, as Dr. Bente was saying. We need the financing, those innovative financing mechanisms. What are you seeing within the countries as you're working with them over the past few years?
Thanks, Joanne, and thank you for giving me this opportunity. I can see some familiar faces in the room, so I'll ask for forgiveness if things that I'm going to say are things that you've heard before. My name is Faustin Mukena. I'm, as Joanne said, Chief Executive Officer of Africa Resource Center. We're a public health institution on the continent of Africa. What we do is as simple as making sure that not only surgical product or gets to the people, but any medicines, any health goods get to them. And we were set up with the idea or the question, answering the question of how is it possible that any fast-moving consumer goods can be found in any village on the continent and easily. And medicines, health products are not available in the national health facilities in the capital city of those countries. So, and trying to answer that question, we set ourselves to be advocates and advisors to government on the continent of Africa. The good news is that we became trusted advisor. We are operating today with local human capital. So when I say that, we're using people who are qualified. Some of them have worked for the government before. Some of them are doctors, medical specialists, public health supply chain specialists, based in the country. So today is 14 countries. We have 3 hubs we operate from to cover the east, the west, and the southern part of Africa. So we have an office in Nairobi, one in Johannesburg, and another one in Dakar, where I just came from. I had the privilege of participating in the research and development launched by Grand Challenge of Bill and Melinda Gates Foundation. And we give this advice, and we became trusted by the government. I'm not going to say because we do it for free, but because we don't send an invoice to the government. We do it because we have people like USAID, people like the Bill and Melinda Gates Foundation, and others who support us so that we can deliver these services. And the way we do it is not the consultant way, meaning that we don't produce a strategy and leave it on the table and leave. What we do is we produce a strategy based on the country profile that we know, because we have experts from the market, from the country. And we produce together a roadmap, and we work with the government to implement that roadmap. And the way we do it as well is to facilitate. We play the broker role between the USAID of this world, all the other partners, the private sector, and the private sector here in a broader terms, not only the pharma private sector, but any other private sector. And the researchers, academia, of course, the government, and any other financial partner that we can work with. And talking about the broader private sector, I just want to give an anecdote, is that during COVID, we saw breweries, for example, stopping production, of course, but producing alcohol for hand sanitization. So that's helped the government, and they came forward. We saw plastic producers company producing buckets so that they can help to put water to put in different places so that people can wash their hands. So these are the type of things that the private sector can do. And in our role advising the government, we try to make sure that the government sees the private sector as a strong partner, even though they're looking for a profit, but most of the time they're looking for a profit for purpose. So how do they understand that and collaborate with them? It's very important. And supply chain is as simple as making sure that they understand it's a chain. And what we design most of the time with the knowledge of the country and the collaboration with the government is to say, yes, you are not expert as a government in everything. So we will help getting some academia to train your people so that they can take over whatever system or whatever solution that have been put in place so that they can own it. So we're not only talking to the ministers, we're also talking to the civil servant in the system because they last much longer, and if they have the knowledge, they will perpetuate that knowledge and they'll continue to work there. So that's in terms of capability building and then managing whatever fund comes to place. And making sure that it's procurement, it's warehousing, but also it's a distribution. And in that distribution is making sure that we're not talking about last mile, we're talking about to the door of the consumer or the people. What exactly do they want and how do they want it? And we can talk more about women and how we empower them. Thank you.
Thank you so much, Faustin. And I think we've talked about the surgical components, the plans, the delivery, and I know we're going to come back to Professor Roma. One of the things is really, what is the financing that is available right now? And Annie, you're a friend, but you also run one of the largest women health funds globally. Mm-hmm. And I think when we're looking at this, we need to bring in the investors early on. That has been sort of when we look at it at a center perspective, when we cut these deals, the investors need to be at the table. So your fund specializes in women's health. Why is women's health such an important topic for private sector investments at the moment? And how do you see surgical care playing a role in that?
Yeah. Thank you, Joanne. And so, to pick up on that, so our fund is an interesting fund from the financing point of view because we are health technology focused. We target market returns for our category, but we also have concessionary capital within the structure provided by KfW, Grand Challenges Canada, and Global Health Investment Corporation. And the reason we have this concessionary layer along with private sector capital is because when we show up and we raise capital from investors and we say things like, we're investing in an underinvested sector that receives about 1% to 2% of venture capital, actually less than 1%. Even the R&D stage before we get involved is 1% to 4%, depending on where you look for statistics for new innovative technologies in women's health. And then we go on and we say all our companies, by the way, sign an impact pledge to bring their technology into the African market to really bridge the gap between a technology being invented in the early 1900s and being available to all people and try to create shortcuts within that. It's a little scary for traditional investors, and so by creating an innovative structure for a fund, we were able to attract very traditional forms of capital that wouldn't not normally invest for global health. And so that's one aspect that we've done to bring in new forms of money to support women's health broadly. But some of what we do is surgical care tools. And there specifically to provide a bit of an example to shape that a little bit in terms of the different ways that creative financing can be used. I'll discuss an example of a medical device where we're looking at potentially funding that is for reattachment of the apex of the vagina during pelvic prolapse surgery. So if we look at all the parts of that ecosystem where we've had public and private sector financing, it's quite interesting. So in the very initial stage of this particular technology, which was, I believe, developed by some fine Harvard professors, there's some public money going into grant financing in the US to fund the initial innovation. Then the innovation was spun into a corporation, and that corporation gets a little bit of grant and some angel funding. Angel funding being return-seeking, and the grants being just that, a grant to further develop the innovation, to create the prototypes, to create to fund the initial early trials. And then the company continues to raise venture capital and grants for the various pieces of its early development. We're looking to come in at what's called the Series A in our stage of funding, which means for us that we've now seen an FDA approval for the technology for version 1 of the product. There's probably 3 or more versions to come ultimately for this particular company. We'll invest together with the EIC, providing a grant for more evidence generation, because although the technology is FDA approved, we still need to have implementation trials for surgeons to get confident about using this device at larger scale and to see the long-term impact of using this new innovative technology. Other funds will invest with us that are not impact investment fund, but they're comfortable investing with us because we know other funders in the ecosystem that will assist with localization of the technology, meaning so if we bring this tool into, for example, the country of Zambia, who's been mentioned on this panel, surgeons in Zambia have to actually test this device to see that they can use it and that they can train their own surgeons on how to use this device appropriately, the same way that it would be used in the US, Canada, Europe. And ultimately, there's, once we get through all of that, we'll probably exit as an investor. Somebody like an Organon or a J&J will buy the company, and they will scale it to the next level into bigger programs that might be coordinated together with WHO. And so as you see, you start from that very first idea all the way to those tools being used globally. There's so many places for these collaborative financings, and they can be done within the investment itself in a collaborative manner in one financial structure, but they can also be done by co-investment, where I invest, meeting my structural needs as a fund manager, whereas, let's say, the EIC that's providing a grant, they fit their mandate for this particular grant as a grant funder, and we coexist and collaborate together, even though we're in a different financial structure. So,
thanks, Sandy.
That's not too technical.
No, not at all. Before we go to a tool, I just have one follow-up question, because I think Joanne's been sort of hinting at something, the fund that we're creating. I know you've been part of this group that's been helping to create this fund of funds. I wonder if you can tell the audience and the people online a little bit about this fund, the process, who's been involved, and what the potential for that fund could be.
Yeah. So our firm, Cross Border Impact Ventures, we launched our fund, had our first initial launch in December 2021, and we're just about to have the final close. And to just give a perspective, this is one of about 5 or 6 funds that I know of in the world that are venture funds focused on women's health. Will be the largest, I think, at 90 million, which is happy and sad. Happy because we got it done, sad because there's so few of us. But to just give a sense of the potential, some of the tools that are used today for women's health, if we think of the speculum, for universally hated tool, it was created in 1857. It's still used today. There's a couple of innovative tools, but it just shows how long it takes for devices that don't work perfectly well, at least from a patient's perspective. I think from the physician's perspective, it gets the job done. So there's lots and lots of room for improvement, and our goal is ultimately to launch Fund 2, Fund 3, Fund 10. But it's been a journey to achieve what we've done. I always tell the story. We've spoken to over 1,500 investors, and to provide a bit of perspective, when I help a startup raise money, I tell them to create a list of 50 to 80 potential investors before they're filled their round. So it was significantly harder to put an investment vehicle together. Very much worth it, and hopefully, we'll be able to continue to raise more funds. And we couldn't be more thankful, to investors in the room like KfW and J&J, who were very early supporters of our fund, and hopefully there'll be more like us.
Thank you, Annie. I just want to say we really appreciate Annie and her expertise from the venture capital side. There's another fund being created, and some of the Ted Trimble's here from the NCI, Joanne from CGHD, and myself, with a group of really interdisciplinary stakeholders, everyone from finance to health experts to supply chain, fintech, microinsurance, those kinds of things. And there's going to be some closing coming up pretty soon. Do you want to say anything about that, Joanne?
Oh, thank you. I think just one of the things that brings us here is surgical care. And as we're closing the larger fund under the Women's Health and Empowerment Network, we raised a soft $170 million of the $500 million fund. We at the center have done these funds for other people and given them away. This time, we have a unique expertise at the table where this fund is being created backwards. And we really appreciate those at the table that are helping us to look at those case studies and know how to deploy the money better, more efficiently. And so we're looking forward to hopefully creating a surgical care window where we can work within the existing capital to address some of the needs that the panelists are talking about. So thank you, Dr. Key.
So now I get to ask my former professor, Dr. Atul, some questions. And as you all know, he's a surgeon, right? And he's an incredible writer. But he's now heading up the U.S. AID, Assistant Administrator for Global Health. And we did a little bit of digging. USAID is also very much invested in this idea of blended finance. And they've published a bunch of really good articles about it. And there was a recent investment in the Transform Africa Fund. As a surgeon, and we're talking about surgical equity here, what do you see as USAID's role, and what's your approach to blended financing and surgical care?
Thank you, Key. So let me put the frame on how I think about making surgery get to scale. And then the private sector plays a critical role in that, but you have to see it as an ecosystem. First thing to understand is that the cost effectiveness of a district-level hospital surgery capacity that can do what are called the bellwether procedures of a C-section, a fracture repair, and a laparotomy, for example, for appendicitis. That enables a capacity that has the cost effectiveness, a cost effectiveness that exceeds childhood vaccination. It is incredibly valuable, but it is much more complex to build and deliver than getting vaccines out in the world, and that is part of the complexity. I've seen nowhere that has been able to really do it at scale and have reach into rural communities, et cetera, without the private sector role. But that private sector role doesn't happen independently. It has to happen, as Bente was talking about, in the setting of an enabling environment for the private sector investments to happen. So a couple examples about what we've done at USAID to enable that environment. In Kampala, in Uganda, we worked with the city authority and the Uganda Healthcare Foundation to develop accreditation and a referral network so that women weren't being transported past private sector C-section capability for emergency C-section and unable to access it. By creating that network and the clear financial flows to help make that happen, you now dramatically expanded capacity by making that happen. The second example is what you discussed as the Transform Health Fund. USAID put in an initial $1 million investment, which leveraged a $10 million investment from the Development Finance Corporation, which then brought in $40 million in an initial round of funding for what's intended to be an ultimate $100 million for the Transform Africa Health Fund for private investment around healthcare delivery startups. And in that space, it's managed by Afric Invest Management Fund, an established, well-regarded fund for being able to do that. And one of its earliest investments has been for Africa Health Network, which has built out now, complex dialysis capacity that otherwise wouldn't be there, including access to the fistula creation capacity you need in order to make that work. So you have to combine the surgical care, the anesthesia care, the machinery, the management work that goes on there. We have made a large investment in 9 countries, building on 15 years with $150 million in obstetric fistula to expand out capacity around safe obstetric surgical care. Once you can deliver that emergency C-section capacity, then you are able to have a capacity at a local level of managing people who have severe hemorrhage, have to have complex anesthesia and recovery capability, manage critically ill people, and that provides a wider capability. And so we've put $80 million into 9 partner countries in our Momentum Safe Surgery program to enable that safe C-section care. But it has to build from pre-pregnancy in understanding, identifying women at risk, being able to build in the procedures for connecting from a primary birth center capability to advanced birth center capability, all the way through to recovery, and being able to make that work. And so it's an experimental effort, really, because we haven't put those pieces together, and it's now in year 2, I think, of launching that underway. I'll say one further thing, a little more complex. The places that I've seen it happen most directly have been related to my family. My family is my father's from a rural village in India. And in 2003, 20 years ago, I decided to go travel to spend some time as a visiting surgeon and I wanted to look for what's the closest facility that served my father's community. And it was 70 kilometers away in Nanded, which is the district seat, that you had to go to the district hospital. That hospital served a total community of 5 million people. It had 8 surgeons and 8 anesthesiologists. When you went to clinic, there would be 200 people in clinic that you would see in 4 hours. I don't even know how you do that, except that I saw it happen, and I still don't know sure how you make that happen. And then something happened. A few years later, India passed what's called the RSBY program, which was a program that aimed to provide an insurance card to the bottom 500 million. So the bottom $500 million, the poorest $500 million in a country of almost 1.5 billion. And that dramatically changed the community. Once you had the means that people could have a card, the surgeons complained it didn't cover their costs, and but they had private sector patients, and now they had a way to cover some capacity to take care of folks. When I checked in, my last visit was still now 6-7 years ago, to Nanded, 120 surgeons, plus anesthesia support, enabling that capacity. And in my father's village, 70 miles away, in the local community, within 15 miles of the village. Now I met their first anesthesiologist. They'd had their first surgical obstetrician and their first general surgeon in that rural area, because now they had the means to provide that capability. And the presence of the anesthesiologist, someone who could recover people, meant that the anesthesiologist was making money mainly on heart attacks. He had a critical care capacity. He could give clot-busting drugs, and he became the go-to person for the biggest killer in the community now, which is cardiovascular disease. And that capacity is how it happens. USAID, probably the single most important thing we are doing is our technical assistance, not unrelated to the work that World Bank does, to enable UHC coverage, to back these kinds of programs and they're coming into existence, and we're backing their efforts in Indonesia, in Philippines, in Kenya, in I can go down the list, in Colombia, every region of the world. And that will do more than anything to enable capacity that then has everyone I described were private sector surgeons, anesthesiologists, and capacity that then has the means to function.
Wow, Atul, that's an amazing story. By the way, there are a couple of people here who are part of the global surgery movement at the beginning. I think Adil Haider's here. Yeah, he's now the dean of Aga Khan University Medical School, and then Atul was also one of the people that that did the initial. And I see people all around here, but the solution to unmet surgical needs is not a technical solution. It's not through surgery that we're going to solve it. In India, it was actually insurance. Right? And I think we're going to hear a little bit more about that in Zambia. The intervention was insurance. So think about, as a person who's advocating for surgical care, I can't do it. I need all of you, finance and investors and private sector to do this. We have our last speaker, and Ian Walker's with the Johnson & Johnson. And Johnson & Johnson was one of the few industry partners from the beginning of global surgery movement in 2015. And the breadth and the scope of how they're involved is, you could probably give us a little glimpse of that. Everything from really projects at the ground level all the way to policy engagement. So Ian, really, we want to hear from you. How does J&J, what are they thinking about global surgery? We certainly are aligned in terms of vision, right? But what's your approach to this?
Well, thank you, Key, for inviting me here today. Just want to talk a little bit about who the private sector are. Who is the private sector? Because the private sector is actually a lot of independent specialist companies. And even when you look at healthcare, Johnson & Johnson, yes, we provide Ethicon sutures or we provide DePuy Synthes orthopedic implants, but we don't build hospitals and we don't provide X-ray machines and we don't provide capital goods. We leave them to our friends at Siemens or GE or Philips to do. We're each in our own specialist area. But private sector cannot do anything alone. And that's where, really, I cannot stress enough, the whole subject of this talk is about partnership. And partnership is what private sector are trying to push forward. I'm delighted to see in the room a couple of our key implementation partners, and Dr. Claude Martin of the AO Alliance and David Cunningham of Kids Operating Room are partners we work with to deliver. And I'm going to tell you a little bit about what we do with them later on. Historically, Johnson & Johnson invested in surgeon training. And there probably is a few surgeons in the room that have been through Ethicon courses or been at our surgical institutes to train. But that's just one part of the surgical ecosystem that Atul mentioned. The surgical ecosystem is not just about the surgeon. We need a much more holistic approach to delivering healthcare and the solution what we're looking for. So we stepped back about 3 years ago and we said, how are we going to look at global surgery in a more holistic way? I've learned in my time of leading the business in Africa that you cannot spread yourself a mile wide and an inch thick. You've got to focus. And where we landed was in Malawi to look at long bone fracture care and in Kenya to look at obstetric fistula. In Malawi, we're working with the Alliance, Kids OR, Lifebox, University of North Carolina, University of Edinburgh, to deliver trauma services in Malawi. And in Kenya, we're working with Jopaigo, the World Federation of Anaesthetists and the Fistula Foundation to really change the landscape, ultimately with the government of Kenya, to eradicate obstetric fistula. Private sector, and where I get asked all the time from my bosses, is what are you delivering that's tangible? Our stakeholders demand, because we're private sector, they demand tangible impact, something that's actually happening on the ground. And to do that, we've got to work on a local basis. And I was going to give you an idea of a couple of the things that we're doing. Faustin and me were talking earlier about supply chain. Supply chain is actually one of the most technical things to get your head around. We hear about the lab to the last mile, to getting the products to the hospital that's needed. That last mile is often the toughest one. It's not about any company and supply chain can deliver to an airport in Nairobi or the airport in Lilongwe or the airport in Lusaka. The supply chain magic is when you can actually get it to a district hospital and you can actually get it into the operating room where it's needed. That takes specialist services. We're also looking in Malawi at safe surgical process. Simple changes through Operation Clean Cut with Lifebox to say, how can we reduce surgical site infection? Sometimes some of the data of surgical site infection is huge in Africa. 1 in 5 surgical procedures in some hospitals in Africa end in a surgical site infection. By simple support of our partner, we're able to reduce that significantly in a matter of months to maybe 1 in 50, 1 in 60. Let me look at one of the stories we're talking about, took from Atul as well, is about the impact we can have. With our partners, the O Alliance and Kids Operating Room, we have really tried to change the landscape for trauma injury in Malawi. In a district hospital called Doa Hospital, which is just north of Lilongwe, we have invested through the O Alliance in OCO training, orthopaedic clinical officer training. We've also worked with Kids OR to renovate an operating room so they can do basic surgical training procedures in that operating room. That district hospital had no trauma services that were functioning. That district hospital serves a population of 900,000 people, and they have no surgical orthopaedic surgeon in place. The procedures, the basic procedures, are done by orthopaedic clinical officers through Johnson & Johnson product, through Johnson & Johnson support, but delivered through the AO Alliance and Kids OR and Lifebox. And just to finish, one of the areas we're looking at as well, in terms of healthcare workers, is the role of women in surgery. We've been supporting a group called Women in Surgery Africa Group, who are part of the College of Surgeons with the Royal College of Surgeons of Ireland. Only 7% of surgeons in Africa are women. Lots of barriers for women to enter into the surgical profession, not least through mentorship, role models, coaching, skills, lots of barriers to get there. This group is phenomenal in terms of trying to break through these barriers, getting a lot of support from the international community, from leaders of international women surgeons, and we're really seeing a change. And it's Johnson & Johnson that's supporting that group to pull things through. And just to finish, I'd like, when we're talking on the subject of financing, I'd like to ask the group a question as well, if I may. None of this is possible. The best healthcare systems in the world will never work without healthcare workers. But does the world view healthcare workers in financial terms as a cost or an investment? Private sector will always look at your staff as an investment. You invest, it's the heartbeat of the company, it's the oxygen that keeps the company afloat. It's not the systems, it's the people. So I would ask the group to think about really changing that healthcare workers are an investment, and the best systems in the world. It's all about building hospitals, it's all about kitting out hospitals, it's all about products, but it's not. It's all about having the healthcare workers, especially in that last mile, to deliver, and they can only do that if they get the right investment and support. Thank you.
Thank you so much, Ian. And I think that, this group has led us through a journey in itself of, both the financial aspects, the supply chain, the role of, donor governments and USAID's innovative thinking around the Transform Health Fund, in addition to the role of the World Bank and WHO. I think this is a group of very much experts and doers. And with that, I'd like to turn it over to Professor Roma. There's been a lot of mention of insurance. I know that you're working, with the WEN network on business modeling with Harvard, Dr. Ted, Kids OR, other partners around the table. Turning it back to you as to what you're seeing for the business model. And I think you also mentioned an announcement.
Thank you, Joanne. And it's really a steep learning curve listening to all these experts in the various fields. And Ian, thank you very much for speaking so eloquently. And I want to agree that really private sector needs to be in partnership with whatever we call public sector, and private sector by itself cannot manage to deliver the expectations. But I think the other side is also true, that public sector by itself will not manage, far from it, to deliver on what is expected. And therefore, the partnership is the key ingredient to be able to deliver, at minimum, the sort of desirable healthcare services. And I think, put in context, if you think about the HIV pandemic, for example, which had a very huge toll on the health systems, especially in developing countries. And I need to say this because Atu is sitting next to me. If the PEPFAR program did not show up, I don't know what the picture would be globally today. Because with the PEPFAR program, we managed to change the HIV dynamic from a literal life sentence to a manageable condition, which now you are even able to laugh about because the patients live a normal life. Now, that's a very big partnership that introduced a lot of sort of resource, technical and financial, into the system to achieve a specific goal. That said, we need to continuously think outside the box and find better solutions, because while that program has been very successful, ourselves as the major beneficiaries are very worried that the system is so dependent on the excess of $400 million or so that we continue to depend on to keep those people on treatment. So what is the sustainable solution to a challenge like that? And this is what I mean. We need to keep thinking. We need to keep trying to explore options, because the PEPFAR solution was not there before, and because of a need, it came up and it solved a very big problem. And I think we need to continue to try and solve big problems. The COVID pandemic is another one that I think slapped all of us in the face as a global community and exposed a lot of weaknesses in the way we think with our systems, the inequities that come with that, the global sort of arrangement on humanity, as it were. But I think that should shake us and make us rethink how we fund and explore solutions to the problems that the world needs. In Zambia today, we have very what I think are very unique opportunities for partnerships, which we're talking about here. And the case of cancer care is really a window or an opportunity to show what is possible. And I think that our government today is providing an environment that is so conducive, in my view, an ideal environment that has never existed before in really putting resource where it thinks that there are actual problems, and put in context again, really without necessarily increasing the production in a short time, able to mobilize, put together resources and ring-fence them for healthcare provision. And I think that should be a stimulation to partners and donors, because here's a situation where the main stakeholder for a problem of interest is demonstrating that with all the limitations, able to ring-fence resource and put money where the talk is. And that's not only just with the over 300% increase in health budget, but it is also in getting the entire constituents development money to the local system. That is moving money from the tune of $1.6 million kwacha before to 28 million kwacha. The quantum of the increase is incredible, but that's the spirit of the government, to take money to where the issues are. And I think the concept of your blended financing here gives us a very unique opportunity, because here's an environment where the main player is taking lead and opening the door. And basically we are, from the highest policy level, are being cultured to say we need partnerships, and we need to drive development with partnerships. And I think in Zambia today, the idea that government serves only what you call the public sector is one that we are trying to reverse. When you talk about Ministry of Health, for example, in Zambia, for a long time until now, people felt that the ministry serves the public sector only. But I think we are coming to the challenge of reversing that. And when you talk about health, you are talking about health of the Zambian people. When you talk about development, it's not just the government or just the private sector. They've got to work together in the interest of the Zambian people. And I think that the investment case for donors and philanthropists becomes, I think, a very attractive proposition in an environment like that. And I think that blended financing, the bit that I have learned in the last few months, I think can never be better than that. I think that there are very unique opportunities here, and we are moving forward with a very open arm in partnerships, encouraging partnerships to deliver, and from whichever angle you look at, what you want is the impact that improves the care and reduces the suffering of the people. And we already established here that no single entity can do that. You need to mitigate and reduce the risk by having many sort of investors and donors to the pool, so that the risk on each one of them is reduced. In fact, instead of thinking about reduced risks, we should be thinking about the potential for greater impact is increased. And therefore, we can make a model here, And I think for us as Zambia, we are saying we want to try whether this can be a model that would be applicable not only to women entrepreneurs, but to many fields in healthcare that you can take upon to make sure that the way the world looks at healthcare, health service delivery is perhaps transformed forever. And maybe other countries can also learn from what we are trying to do and really have a better world tomorrow. But this is what we are saying from Zambia, that it is time to try something unique, something new. I think there will be a lot of learning along the way, but this is what we have to do. And I think that the invitation is out there to people who want to come along so that we move together. Thank you, Joanne.
Thank you, Professor Roma. And I know you have a business model that you're working with both the insurance and the telecom. So I think, that we're going to distribute that for you, and thank you. And I know you're heavily thinking also about the surgical care interventions, working with David from Kids OR. So that business model will go out. And I think this is a time where we want to also open it to the audience. I see a lot of experts here, and I'm sure you have questions of the panelists as well.
I just want to clarify. Professor Roma, if I heard you correctly, the Zambian government is committing up to $30 million for advancing women's health in a blended financing type of structure. Is that? Am I saying it right? I want to make sure I get this right.
I think the correct interpretation and understanding of what we are saying is that the government of Zambia has signed off on an agreement in which the government is going to invest $28 million to basically provide cancer treatment services, specifically improve the radiotherapy for cancer patients. And we are saying with that specific investment, can we look for matching opportunities through your blended financing and other sort of pooling of resources that then provides an end-to-end care, because that investment that the government is doing is specific to a part of what cancer patients need, and there are still gaps. And let's use these opportunities for investment to have an end-to-end setup. And as a matter of fact, Dr. Kia, I must announce here that beyond that, in the coming year's budget, the government of Zambia has committed to building a couple of cancer facilities on the northern part and on the Copper Belt. And I think that is going to go on. And I think this is why we think it's a great opportunity. Yeah.
Congratulations, Professor Roma, on such a great announcement, and also on the business modeling that you're working with the private sector partners. I see some questions in the audience.
Hi, yes, I have my first one. I'm Serena Cruz. I'm the chair of the Advocacy Working Group for the G4 Alliance. So I'm very excited to support our PC member, Harvard, PGSSC. I also see some familiar faces from the conference so far, and one of the speakers here, Dr. O'Toole, from the Global Surgery Foundation event we did in Geneva. So I've been attending the circuit this year, and I've been taking in a lot of feedback around what are we going to do about global surgery? What are we going to do about surgical system strengthening, perioperative care? And at the same time, I'm hearing a lot of fortunate things happening, sort of service delivery by service delivery. And because I sit in the advocacy space, and I do Professor Roma's points about HIV hit home, because I did spend a lot of years working in that field. And so what I want to know about this effort we're doing in the name of global surgery is, at what point are we going to start to coordinate, like the kind of coordination we've known has been necessary for every other health response. And who's going to coordinate that, right? We have the Global Surgery Foundation, we've got USAID's efforts, we've got industry efforts, and then we've got advocacy and coalitions. But there has to be at some point a coordination, a mechanism that's bringing us together, not just financially, but really making sure we're not duplicating here, that we're not making the same mistakes as the fund. Thanks.
Yeah, that's a great question. And if I may, I'm going to pass that question on to Bente.
Yeah. So, thank you for the question. And I think, when we look at, we have not published this yet, but we have looked at the coverage of cancer treatment in UHC, and that is not super optimistic. And then if we look at the surgery included in the essential benefit packages for cancer in UHC, it's approximately 50%. So first of all, there is a huge need to really define, what is needed. And I was very intrigued by your intervention, Atul, because I think if it is true, and I'm sure it is, that it is a business case of cost effectiveness that needs to really come true. And I think we just updated, as you probably know, the cost-effective interventions through WHO, what we call the Appendix 3. And I don't think we put it there, but the good thing is that we can now we have a mandate from the member state to do a continuous update. So I think that is a very important thing. And I will offer as well, we have the 4th high-level meeting on NCD coming up in 2025. And we have a mandate to prepare. And we are doing a lot of things on the road to 2025. So one of them was the Appendix 3 update. It's emergency, which can also actually offer some interesting perspectives into the discussion about surgical capacity, And we are also having a meeting specifically on financing happening in June next year. But we are also going to launch the status on cancer as part of the appendix. So you have, as a, let's say, advocacy community, a very good opportunity to raise the awareness. And honestly, this is not authorized WHO language, and of course then it's quoted 10 times more. But we need to think through, do we have tracers that can tell us something about management on cancer? Because we don't really have good tracers. And I'm looking for these tracers. We do the tracers for hypertension, or we will have tracers for diabetes. Do we have tracers? And maybe even surgical capacity could act as a tracer, at least an idea that we could explore. So utilize the momentum of the political awareness raising, try to push and support WHO to include also cancer treatment, surgery, and not only cancer, by the way, but surgical treatment into the essential benefit packages, and continue to support and align the action at the country level so we can have the last mile, absolutely agree, and the human resource capacity done. And I want to end with one thing, because I really think Monique offered something. I'm a gynecologist and obstetrician, and I'm also, shocked and very sad about the high level of C-section. And, if we took that capacity and offered that for cervical cancer elimination and the management of cervical cancer, suddenly we have already a small solution at least, and we will not be able to grow probably very much the healthcare capacity. We have to allocate it more globally. But, if you look at the prospects, we need to be much smarter on how we work. So thank you.
Thank you. That was really helpful.
Oh, Monique, follow up.
Yeah. Thank you, and we are at the World Bank very comfortable with the WHO taking a strong role in coordinating all of us. But I want to make one other point, because what really strikes me is that we've done a lot on developing the financing tools. And so I, for example, think the GFF window for blended financing with IFC now has a lot of potential in this agenda. But I think a much bigger challenge we have is the public image around the topic, because I'm sitting here listening, thinking the last 10 conversations I had with ministers of health, nobody raised it as their top priority or something for us to help them address or strengthen. And so I think there's something to be thought through around why is that, right? And building on what that tool said about having some sense of simplicity around, it's really about 4 or 5 procedures that every district hospital, and are we talking about that when we engage with countries, right? And because I think it really needs to be driven by countries feeling the need to invest in this and improve it.
I'll just briefly point out, it was in fact a World Bank publication, the DCP3, Disease Controls Priority 3. We had 1 volume devoted to the surgical platform, that all the cost effectiveness work was there, and it put out the concept of the 3 bellwether procedures that are what we can build on. So that's almost 8 years old now, and there's a chance to really move it forward.
And we don't even read our own publications when it is.
This turns into a sad meeting.
Other questions? So the person with the mic.
Thank you very much to all the panelists and of course the organizers. My name is Jacopo Tomasina. I do work for Emergency NGO, which is an NGO who in a nutshell provides mainly surgical care in fragile and affected countries. I just have a short question. Has been mentioned that all of these is a complex ecosystem. We talked about enabling environments. So my question to all the panelists is, where do you see the civil society in all of this? Because civil society can be enabling partners, can be implementers, can be supporters, but it hasn't been, I mean, the topic is complex. I hadn't heard anything about it, and I thought this might be the right moment to ask a question about it. I just to pick some of the comments of Mr. Walker, for example, in the training and building competencies field. Civil society can support because, as has been said, it's impossible to have surgical care without surgeons. And so in that field as well, civil society can play a role. But in general, I want to hear from all of you, what is your point of view about civil society in this complex ecosystem, how it can become enabling partners? Thank you.
So we have time for one person to answer that question. Ian, you raised your hand first, so please go ahead.
I could answer that. Civil society is crucial in this. The challenge that surgery has had is it's been low down the priority list over the last 10, 15, 20 years. And we're all in this room because we have an interest in surgery, and I think it's on us all to basically start talking the story about the impact that surgery can have. We've heard this morning about a lot of the data points about the huge unmet need that exists in surgery. That cannot be delivered and addressed by one group or one person alone. It's going to take partnerships, it's going to take all of civil society, and not least when we get to the ministries of health and the ministers in the local countries who set the policy, set the agenda that many of the civil society will follow. So the answer to your question is, I don't know if it's the answer you want, but it's yes, it's everyone. We all have a duty.
Thank you very much. Thank you. My name is Esperanza Martinez. I worked for many years for the International Committee of the Red Cross, and I actually lead the health and human security agenda of the Australian National University. There are many countries experiencing political upheaval, including in Africa, and more than 100 countries or contexts in the world affected by armed conflict. And we also know that in this context, surgical needs really scale up. They grow. And the capacity of the public sector to respond diminishes. But we also know that the appetite of investors in unstable and fragile settings is really low. So my question to you is, what is the current thinking about public-private partnerships in contexts that are unstable and fragile? Because if we don't crack that nut, we're just really not going to advance in areas where the needs are unsurmountable. Thank you.
Maybe offer a few thoughts from my prior employer, Grand Challenges Canada. When I was there, we launched a program called Hope in Conflict, I believe it was called, and it has to do with funding innovation for regions of active conflict. And this program had been funded by a number of governments that provided, grant funding to Grand Challenges Canada. And I believe there was USAID was a big funder. We had, I think the German government, one of the entities was a funder. Government of Canada came in. So a number of partners, was about 8 in total. And what they had done in the lens of private sector partnerships is the way the RFP was built was companies and civil society organization, anyone who was an innovator really, could apply for a grant of up to 1 to 3 million. I believe it was, going by memory. But it was specifically to bring an innovation to improve the lives of people in regions of conflict. And we saw a number of projects come through that ranged from, for mental health. They'd have gardening programs to allow people who were, really stuck in refugee camps for sometimes a decade or more to sort of improve quality of life, down to we had some high-tech companies apply with systems that would help detect if a live conflict was coming near where the humans were living, to clean tech projects to bring in power in the DRC and other live regions. So it is possible, and based on that experience, what I would say the learning from that project that at least I took on is, again, this concept of bringing in public money on top of private sector capital, where the private sector capital is used to kind of build out very expensive technology in some cases, but bringing in that little layer of public money to tailor it to that particular use case, because the private sector, private companies just don't have the risk appetite to go there, but they often have employees within those companies that are very interested in making the world a better place. And typically corporations, through their corporate social responsibility programs, are able to dedicate employees so long as there's a sleeve of money to make that work.
Thank you so much, Annie. And I know people are going to other panels, so I wanted to thank everyone and all of the diverse expertise here. I think, thank you, Annie, for your contributions, also with the explanation in terms of the financing. That is really, what's needed. And, the focus on surgery, that's been a very low priority for sustainable financing, and now I think rising it to the top is very important. Kia, I'll turn it over to you to close.
Yeah, I just want to say thanks to everyone, especially our panelists who shared their time and their wisdom with us. Let's be real. More than half the healthcare delivery around the world, including the developing world, is delivered in an out-of-pocket fashion. People purchase it. It's about $5 trillion a year. The money is there. People are already paying for healthcare. I think the job for us here is to figure out how to harness that money and rechannel it and put it in a system that delivers most equitable care. And I think there's a way to do it with profit. There's revenue model involved with it. So that's sort of my take-home message. Thank you, everyone, for being here, and have a great day.